Okay, so let's start MR of the lumbar spine. And just a little bit of statistics. This was from a publication a number of years ago, but it looked at the cost of medical costs of people who have spine disease and people who do not complain of spine disease. And this is from 1997 into 2005. It's actually widened a little bit since then, I believe. But what you can see here is that there's significant higher costs of people who complain of spine disease to their doctors than those who don't. It's roughly double the overall medical costs, which is runs into a lot of money. And here's just 1997 per capitation of spine problems went up from basically 47 up to 61. Without spine problems, much lower increase from 27 up to about 3,500. And while the costs went up over this time period, if you do an analysis of the functional limitations of the people with spine disease, it actually worsened. It went from 20.7 up to 24.7 during that time frame. So the costs went up, but the actual outcomes went down. So this was published back in the early 2000s, and the results, I mean, the conclusion in this paper in JAMA was that spine problems may offer opportunities to reduce expenditures without associated worsening of clinical outcomes. They actually implied that it might improve outcomes if we started limiting spine procedures. Around this same time, this was a typical advertisement. This was in the LA Times. We can see LA Times, December, let me move, 4th, 2008. And this is a big ad advertising for non-surgical medical treatments for spine disease, basically claiming that spine surgery was dangerous. This was in the LA Times as an advertisement. So what do we know about the epidemiology of spine disease? There are high rates of MRI correlate with high rates of spine interventional disease. And the more MRIs that are done in a patient population, the more surgeries that are done. And this was also found in this JAMA article from 2003. So the recommendation at this time was that the number one strategy to decrease spine interventional rates is to actually limit MRI. And this is really one of the strong features that started the concept of utilization review, especially looking at radiology procedures. This utilization review or prior authorization has become really a bane in the medical industry. There are a lot of recent articles saying that it causes increased costs, not decreased costs, and much poorer outcomes in U.S. medicine. It started out in large part because of this problem with people getting more spine surgery actually had worse outcomes. And that in large part was driven by the use of MRI with improper interpretation of the significance of MR findings. So that's what we're going to talk a lot about in the next week, are what MRI findings actually mean. Well, don't need to go through the basic protocol. We are going to talk a little bit about special protocols, which we don't use very much. Talk a little bit about the value or lack of value of contrast enhancement and looking at post-op disc versus scar. Contrast is, I believe, useful for non-bony neoplasms, but not very useful for degenerative spine disease and disc disease. And I'll talk a little bit about some studies that we did doing upright scanning and flexion and extension and in the sitting position. So a little bit about technical aspects. So let me see here. Jason, this is a patient had back pain after an auto accident, and this is a patient in litigation. And
Okay.
as I told you guys, John and I have done probably each of us over 500 cases of involved with litigation and personal injury cases. So this is something that John and I have had many decades of experience with. But what do you see here?
All right, so at L45, we see a decreased signal in that disc with a small central extrusion.
Okay, and we can see that coming here. It abuts but doesn't displace the nerve roots there. Uh, so there we go. We can see that disc. So this disc is at this level, and this disc is at that level. Uh, now, okay, so this is, uh, and they called the bulge at the L5S1 level. So this was, the radiologist thought this was a transitional vertebral body, and that this was L5. Uh, and then the patient went to surgery, and this is the postoperative films at surgery. What do you think?
I think they operated on the wrong level, right?
So at surgery, they went in, and where there you can see the postoperative changes, and the surgeons didn't have sufficient space to put in an artificial disc, which is what he was thinking he was doing. And we'll talk about surgery and artificial discs later in this talk, in a couple of days from now. And you're right, the surgery was really at the wrong level. And this points out that there are common congenital anomalies really at the lumbar sacral junction. And it's very important to be clear in your report. The radiologist actually did call it correctly, and the surgeons just misinterpreted at the time of surgery. But it's very, if there is any transitional anatomy at this level, you've really got to make it in your impression and make it clear that it's not missed. So this patient uh, was had persistent symptoms, so they were litigating really over the wrong things. I mean, they ended up being litigating over the cost of surgery, as the patient actually did well, but it wasn't because of the surgery. Okay. Robert?
We have a 66-year-old anticoagulated with left hip prosthesis and left-sided back pain. Rule out discitis or epidural infection. We have an axial of the spine. Uh, the lumbar spine itself looks okay. There's at the field of view on the left, on the right. Looks like there might be something there. Yeah.
And this is a large field release. What's happening here?
Looks like it's a fluid collection. There's a lot of edema surrounding that. Oh, so hematoma maybe.
Yeah. So this is called hemorrhagic bursitis, but it was really hematoma over in the pelvis. So just remember, everybody warns you about the edges, but what I like to do at the end of looking at lumbar spine studies, I like to look at the edges of the images, and most importantly, I like to look at the retroperitoneum, because it's easy to miss retroperitoneal disease, and we'll see how some of those can masquerade as spine problems in future lectures here. Okay, so what do you think here, Elior?
Okay.
So this is a T1 weighted image on the left, pre, and this is T1 weighted image on the right, post contrast, IV contrast.
Okay. So looking at I think the L45 foramen, we see enhancement of that dark signal on the pre.
Yeah. So I don't know, in your residency, did you guys do a lot of pre and post contrast spines?
Yeah, and it was to look for either demarcate between granulation tissue and disc fragments after discectomies.
Okay. Uh, so so how reliable was it? And what's the indication for when do you have disc fragments and when do you have, how did you use contrast to help you with that?
So yeah, so post-surgical spines, um,
If you saw enhancement, what did that mean?
it meant it was granulation tissue.
Okay.
Yeah.
Uh, okay, so this patient has not had surgery. So what is this contrast enhancing?
I mean, could it be a lesion, not part of the disc, maybe a nerve sheath
It's
tumor?
this thing right here. Could be, but it's really part of the disc. This just shows you that it's common for degenerative discs to enhance.
Okay.
So the fact that if something enhances it does not mean it's not disc. So you have to be very careful. And as we'll talk about that later on. We'll show that they're, well, I'll wait till we get there. Never mind. So we'll come back to this issue later. And one of the reasons why we almost never do pre and post contrast imaging anymore, I certainly don't recommend it, is that it's not reliable. And it turns out that's not an important distinction to make, as we'll talk about later. Okay, Taysom.
All right, 74-year-old male with back pain and foot drop for 5 years. So it looks like we have diffuse disc desiccation. There's some narrowing at L23.
And some reversal of the normal
Yeah,
curve.
the reversal of the.
So what I'm really, this is the T1 weighted fat sat post. And what do you see here?
Yeah. I don't know. Is that venous flexus? No, it's
So if
not.
we come back here, looks like there are disc protrusions there, right?
Yeah.
And the little signal in the disc there. If we do the post contrast, it looks like those disc protrusions are enhancing.
Okay.
Now, this patient has not had surgery. The other thing I want to point out here, that I'll make the point in many future lectures, you can't call this disc enhancement unless you have an identical pre-contrast sequence. So a lot of people will do T1 weighted pre and T1 fat sat post. If you do that, you're going to grossly overcall enhancement because a lot of these discs and other structures that enhance that look like they enhance with contrast, what you'll find is that they'll be as bright on the T1 weighted fat sat because when you do fat suppression, you change the contrast. So many radiologists will save time by not doing a T1 weighted fat sat pre. They'll just do a T1 pre and a T1 fat sat post. If you do that, you'll not do your patients a service because you'll do a lot of overcalling on contrast enhancement. I'll show you many examples as we go through.
Yeah, but the surgeon, he'll get mad at you if you don't do it this way.
I'm
I
sorry, say
mean,
that
after
again.
all, there's money involved.
Okay. So, yeah, but see, the surgeon, John, wouldn't want you to do it this way because this is enhancing, and therefore it must be scar tissue, and therefore it's a non-surgical condition. So by doing it wrong, you're actually going to cause something that they can't operate on. But
Oh, I'm sorry to
I'm
hear
kind of
that.
joking there a little bit, but actually, there are examples where I've seen that. Well, anyway, we'll talk about that later.
I'm kind of kidding around a little
I
bit.
know you are. Yeah, right. And here we can just see on the T1, there's really not much. There's really very little, if any, enhancement between the two on the T1 pre and the T1 post. And then that just shows the T2. So that's another case where we have disc enhancement of discs, but the patient hasn't had surgery, so it's not scar tissue. So the bottom line is I do not think that MR is very reliable. I mean, it can, to a limited extent, differentiate scar tissue from non-scar tissue, but I've seen a lot of errors in that. But as I talk in further lectures with further data, it's not really an important distinction to begin with, but I'll go do that later.
Are you talking about granulation tissue or scar tissue?
Scar tissue, post-operative scar tissue.
Okay. That enhancement is granulation tissue, isn't it?
Well, classically, you do with and without contrast in the lumbar spine in postoperative changes. And the previous teaching were that if the tissue that you're concerned about enhances, it's postoperative scar tissue, and it's contraindicated to do surgery in them because reoperating will only make the scar tissue worse. Whereas if it's a mass and it doesn't enhance, then it's more likely to be disc, and therefore it could be a cause of symptoms, and that's an indication to do surgery.
I see. My question was that granulation tissue enhances, but old scar tissue doesn't.
Old scar tissue doesn't, but
Yeah,
young
and
and
that was
medium
an
age does.
old person that we just looked at.
Right. Right. Yep. I agree with that.
So yeah, I'm just questioning that a little bit.
Yeah. Good. Now, I just want to say something here, and I'm going to come back to this later when we talk about upright imaging. And that is, if you actually measure disc pressures in people, this is an article from 2019, the average pressure in your discs when you're standing is about well, this isn't a issue of measure of kilograms per square centimeter. The average sitting pressure is about 140. So actually, you've got more pressure on your discs when you sit than when you stand. And that's because when you stand, you in natural position, you offload a lot of the upper body weight to the posterior elements. Which in sitting, you're typically seated, you're leaning more forward, and therefore you have actually less weight on the posterior elements. So as we'll talk about in a minute, one of the justifications for doing upright MR scanning is that you would increase the pressure in the disc, and therefore you might pick up disc herniations that you wouldn't pick up if you were lying. And but it turns out that you have more pressure in the disc when you're sitting. And if you sit with forward flexion, it goes up significantly, almost to double what it is if you're standing. But then if you go to forward flexion and lifting, like if you lift without bending your legs, then you get the highest pressures, which is the reason why your parents told you always to bend your legs and lift with your legs and not with your back. Now, there are a number of scanners that we've used in the past to do upright scanning. This is a phonar scanner. Phonar was the first company to create a commercial MR scanner. It wasn't superconducting in its first version. The second company was Dysonics, and the first clinical diagnostic MR scan in the world, superconducting scanner in the world, was put in Huntington Hospital out near Caltech here in Southern California. And then here are just studies using the phonar scanner, which you can do upright, but we found that if you stand, there's usually too much motion. So most of the upright imaging we did was actually with sitting. Here is with forward flexion, neutral, and extension. And one thing we saw is that you commonly see a little bit of worsening central stenosis in the extended position than in the flexion or straight upright position. And one thing we also did find, however, is that if you're flexed, you decrease the amount of pressure on the facet joints. If you extend, you increase the pressure on the facet joints, and this can often make the facet joint cysts larger. And this is one not uncommon, but not really common cause of central stenosis. And you can see that better in an extended position.
One thing, though, most herniations occur with the patient flexing. And that's probably because of the pressure that is produced, i.e. like a lever type of an event.
Yeah,
So in my experience, patients have told me that they bend over and all of a sudden they couldn't stand up.
right.
It's great.
Yeah,
So,
if you put your weight forward, you shift more of the body weight onto the disc and vertebral body column. If you extend it, you shift more of the weight back to the posterior elements. Right.
Right. So
You did the last one.
in the scanner there, it looks like the position is worse than the extension, and that
Well,
what I see there is the patient is more labile. I mean, more flexible in extension than in flexion.
yeah. Well, you see, there isn't any change in the discs here. What changes is the AP diameter of the neural canal in this location, and that's commonly due to the shifting of the bones when you go to the extended position. But in fact, you can maybe see that there's a little bit of anterior listhesis at 4-5 in the flex position, and that goes away in the extended position. So the bony anatomy shifts a little bit from flexion to extension, but you can see there's no change in the disc protrusions in this particular patient. And that's because their problem is not with a disc protrusion. Their problem is basically with a little bit of a bony narrowing of the central canal. But we'll talk more about all these things in detail
Got it.
as we go forward. Okay, Robert, what do you think this area is right here?
That's right. Is this a T1 sequence? I mean, it could be like a hemangioma. Not entirely sure, just based off this one image.
Okay, here's this image. Now here's another T1 weighted image that was done about 5 minutes later, and it looks like this. What could do that? Or let me ask you this. What did we change in the protocol? Okay, let's go back here. So this is the aorta. And one thing that you can get if the TR and the pulse rate is similar is you can get motion artifact, which can propagate in the image. And this is actually a motion artifact from flow in the aorta. So what we did here is we changed the phase encoding to right to left. Generally, we always do imaging with the phase encoding from right to left now. And then there are modern techniques that actually can get rid of this altogether, and that got rid of that flow artifact. Okay. Anyway, let me just do this one. So here we have someone who had prior surgery. We can see a lot of scar tissue back here, obliteration of the right half really of the neural canal here. When you give contrast, you can see that there is some enhancement here. So this would be indicative that this could be a disc in this case, and therefore maybe this patient should have surgery. There are a couple of problems here. One is occasionally you can have very subtle metal left over that can cause problems that sometimes can masquerade it. And as we'll talk about in a little bit, as we go forward, it turns out that scar tissue doesn't change the prognosis, and actually disc fragments there actually don't change the prognosis in large studies. But this is the reason why we used to do pre and post contrast imaging in patients who had postoperative primarily radiculopathy, because this really shouldn't cause back pain more than compression of the nerve during radiculopathy. Okay. So let's look at some other statistics here. This was from 1991. Back pain from degenerative disc disease was felt at that time to affect 65 million Americans. That's about a third of Americans at that particular time. And that's one of the major causes of disability in the United States. And in 1991, the costs were about $100 billion. This number has basically tripled since then. Chronic back pain we knew was uncommon in the medical literature before 1900. Before 1900, back pain was almost always infection, and part of that is probably because most people got back pain and it was just part of living and nobody thought of it as a medical problem. And also a lot of people didn't live long enough to get the typical degenerative back problems that we have in today's world. And the other thing, as we'll find out in a minute, one of the major causes of back pain in the modern world has to do with lack of exercise and having a sedentary life. And in the 1800s and before, most people were very active, kept their muscles in good position. And it tended to be more of a city thing then. It's rarely due to a single traumatic event. It can be, but that's really very uncommon. And mostly it comes from couch potatoitis or basically from sitting. And we'll explain the pathophysiology why sitting is very bad for the back. So what can cause back pain? Well, it can come from a number of different factors. We'll be going through some of these. You can have muscle injury or fatigue, which compromises the stability of the lumbar spine, resulting in shearing forces. And those shearing forces primarily on the static elements of the spine, which are the capsules of the facet joints, the annular fibers of the discs, get stretched and partially torn, and that's probably a major source of pain in people who have common everyday degenerative back pain. And this can also lead to degenerative joint and disc disease. Yes, John?
Excuse me, John. There are a lot of nerves around the spinous processes, and so movement obviously puts a stress on these nerves, and some of them get irritated and cause pain. So probably most of the pain that we get are probably from daily activities where your nerves around the spinous, either the disc, there are a lot of nerves around the discs, and there are a lot of nerves around the spine in general. So it's not unusual to have pain. And the thing about the nerves, they're very close to the bone, and any movement or any pinch in that area produces pain.
Yeah.
So I would say that most pain is probably not disc related.
Right. It could be the annulus, and this is from hospital special surgery where they looked at this. And so what they were saying is that what's actually very important for chronic low back pain especially is the strength of the core muscles, the pelvic floor, rectus abdominis, internal external obliques, and transversus abdominis. They are key because these are important for stabilizing the spine. So if when you move, there are actually there are really huge amount of muscles and submuscles within the spine, which keeps all of the different elements of the spine properly aligned when you flex, extend, when you put weight on it, and so forth. And the muscles are responsible for keeping the bones and the joints centered properly. When the muscles don't work, if they get fatigued or if they're injured, what happens is the bones shift, and then the joints are held in place by the capsules and the ligaments, not the muscles, and they're really not designed to handle everyday chronic stresses, and they stretch and partially tear. And as John said, they're heavily innervated. And so that's where probably most of the pain occurs, according to these people. And that the spinae erecti muscles are also very important in properly maintaining the joints to be properly aligned. Sciatica is pain that radiates from the buttocks downward along the course of the sciatic nerve. It's really differentiated. That's a definition of sciatica. There are many causes of sciatica, and I'm not sure we know all of them because a lot of sciatica we can't really come up with an anatomic reason for it with imaging, but you can see that the sciatic nerve emanates from the lower lumbar and spinal nerves that come out. They go through the in here through the greater sciatic foramen and down into the nerve, which we see here to produce the tibial and peroneal nerves. So the etiology of back pain, it can come from the end plates, from the pars interarticularis, the vertebral bodies, and other bones. It can come from the joints, like the facet joints and the uncovertebral joints. It can come from the discs, especially the annulus, especially when you have disc protrusions. It can come from compression of nerves by a disc, either discs or bones, or from inflammatory disease of the spine. It can come from the soft tissues, ligaments, tendons, muscles, capsules, and a big cause that we have to deal with every day in medicine are there a lot of psychological causes for back pain. And we'll talk about some of the studies that have looked into the psychological causes of back pain as well. So if you categorize...
Excuse me, John. Before you leave that last slide, vertebral bodies themselves do not have any nerves. It's only the tissue around the vertebral body that has nerves.
Well, actually,
Cancellous bone does not have nerves.
some of the treatments actually obliterate the nerves in the vertebral bodies.
Well, I don't know what they're obliterating, but I've perforated many tibias for traction, and the only nerves that were present were in the periosteum. So, vertebral body itself, the cancellous bone, as far as my experience, there are no nerves.
Interesting. Well, we'll
But
come back to that when we talk
if
some
you
of the
put pressure on it, if you try to aspirate the disc, I mean the bone, vertebral body, if you try to aspirate it or inject it with something, you're going to have severe pain, but that's from pressure or deep pressure.
Okay. All righty.
So I don't know why they put in a vertebral body per se.
Okay. We'll talk about it a little bit because one treatment protocol actually puts a percutaneous device into the center of the vertebral body and actually burns the center of the vertebral body, which is supposed to destroy one of the nerves that go to the end plates, and that's supposed to alleviate pain from end plates. But
Well,
we'll talk about that
then
later.
they should burn the end plates.
Okay.
Well, it's something that I disagree with that fellow, whoever that is.
Okay. Well, I don't see any of those procedures around in Southern California, and I have not thought that made any sense to me either. But we'll briefly talk about it when we talk about treatment protocols.
Okay.
And then typically categories of back pain, people can say it's discogenic, actually from some area of the disc, neuropathic, osseous. You can get it with metastases, necrosis of the bone, fractures, infection, and type 1 modic changes. Some people believe can be symptomatic. And then from the facets, and then myofascial could cause pain. We'll look at this slide again later. When it looks at the nerves, you can see the nerves come out here where you have the dorsal root ganglia that you're all familiar with, coming from the cord or the cauda equina, lower down where we are now, into the neural foramen, and then a lot of nerves come off here, which go around and innervate the annulus of the disc.
They're missing the sinovertebral nerve, which is one of my favorites. There, a lot of books don't include them, but the sinovertebral goes centrally, and it may go up to 2 discs or even 3, and that's something that's um, stretched sometimes and causes pain.
Okay,
It's I learned that from neurosurgeon.
good. All right.
That's not included in that picture, but that's okay.
Okay. And then there are a lot of pain pathways that have been described, and where some of the different treatments can impact the pathway of pain in these particular areas. So, given treatments, but we don't need to go into the details here. Now, what's thought to be one source of pain is the end plates, which we see here, typically in Modic type 1. We'll talk about Modic disease in later talks. And that you have the main artery extending into the vertebral body, and then you have these little arterioles going to the end plates. These are also the source of nutrition for the discs, which we'll talk about probably in our next lecture, or maybe get to it in part of this particular lecture, where you don't actually, in normal disc, have vessels going into the discs, but you get diffusion from the end plates. And that's not a very efficient process, and that lack of efficiency is probably a major cause of degenerative disc disease, from malnutrition to the cartilage cells within the vertebral body here.
Then the vertebral bodies are very vascular, and surrounding the vertebral bodies, there's a lot of vascularity.
Yeah, but and the normal disc is avascular, and we'll talk about the diffusion patterns of nutrients into the disc.
I'm talking vertebral body, John.
Right. Uh, and then there are a lot of different treatments. We'll talk about some of these. If it's discogenic, you can do a discectomy. You can do an intradiscal injection. In fact, one of the diagnostic procedures in the past was discograms that we'll talk about, where you inject contrast in the disc, you increase the pressure. If this reproduces the patient's pain, then that was the definition of discogenic disease in the past. And that's much more controversial now, which we'll talk about. And to treat it, you can do an intradisc injection of lidocaine. You can do electrothermal annuloplasties, where you basically put in an electrode and heat it to destroy the part of the disc. You can put in RF, and I'll show examples of this and what it looks like with MR, to destroy the nerves and decreasing the nerve supply to the end plates, to the disc, which can improve symptoms, and then a lot of other things. And then if it's neuropathic, you can give a number of treatments for neuropathic disease, myofascial pain, facet pain, where you could do injections, steroid injections, epidural blocks or medium branch blocks. Neoplasia, you can treat the neoplasia, and then obviously if it's infection, you treat for infections. Well, one of the things that we'll show about that, if you look at the actual literature for chronic everyday back pain as people get older, right now still the most effective treatment is actually appropriate exercise. So a big cause of spine degenerative disease is actually a lack of activity. That's because when the muscles weaken, they no longer, they fatigue very readily. And then if you sit all day long and then you go out for a hike, your muscles will weaken very early on. They won't maintain the proper orientation of all the different facet joints and end plates, and that'll start tearing the capsular fibers and the annulus, which then can lead to degenerative disc disease or facet disease. as you damage the static elements, which are the ligaments and the annulus. And then this eventually, if you get enough disease of the annulus, that can lead to weakening and herniations of the nucleus pulposus through a tear in the annular fibers and Sharpie fibers, which we'll talk about in detail in a minute. I don't know if any of you guys are astronomers. Modern telescopes actually have multiple segments in them. I don't really want to go through this. We won't go through that. But this is basically the complex kind of a bony anatomy of the spine. We have the facet joints and the disc itself, and all of these multiple joints throughout the spine need to be in proper alignment really at all times, and the muscles have to fire based upon the amount of stress on each of the joints at any given time, as well as the amount of pressure. So it's a very complex process, and you need an intact neural system to get information back from the receptors in the annulus and in the muscles as to the amount of strain that's involved. That has to go through the brain, feedback coming down, then induce the appropriate contraction of the muscles to correct whatever abnormal strains there are in the different ligamentous processes to keep the strain from being too much where it actually tears the capsular and ligamentous studies. And so this is something, and sitting all day long, like unfortunately most of us do, actually inhibits this whole process that we'll talk about. And therefore, couch potatoitis is one of the major causes of the development of degenerative disease. And the strength and stamina of the spinae erecti muscles and other support muscles are actually very important, and we'll talk about this. So here are the major spinae erecti muscles, which help support the spine. I won't go through all of these. I think you're probably all kind of aware of this anatomy, but I think it's important every time you interpret an MR scan, really of the musculoskeletal system, you need to say something about the muscles, because they're really very important for normal physiology, and especially in the spine. The amount of atrophy you have the muscles here is important as a cause of pathophysiology of disease. So here we see very well developed psoas muscles, and the spinae erecti muscles are all in good shape. Here's someone who has severe atrophy from basically being bedridden. And you can see if this person were able to get up and try to walk around, you would have no muscles. And if you put pressure then on the spine, the facet joints would be held intact only by the annulus, by the ligaments. And those ligaments aren't designed to handle chronic strain. They stretch and tear, and it leads to instability, which leads to degenerative disease. So the muscles are important in the normal physiology of spine. And these are two papers that have looked into this, showing that muscles are very important for maintaining normal physiology and protecting the spine from degenerative disease. Causes of the atrophy are mostly is just lack of activity. Surgery can also do it, and I'll show examples of this. Fortunately, modern surgery of the lumbar spine is very different from the surgery we had a decade or two ago, and major muscle injury, that is the injury to the nerves which innervate the muscle, is much rarer now than it was even 15 years ago. You can also have primary muscle disease, which can be a problem. Infections and trauma can affect the muscles. And then we'll come back to this slide in a minute. This is from the North American Spine Society, and this comes from the ASNR. You can have a normal disc with a mild degree of normal aging over time. You can have congenital developmental variants, degenerative traumatic lesions, which are what we're going to be talking about the next few lectures. And then later on, we'll talk about infections and neoplasms. So when we look at disc disease with MR, there are a number of things we need to evaluate. We need to look at the nuclear signal intensity, which is primarily an indication of the hydration level of the disc, which is highly associated with the biochemistry going on in the disc and degenerative disease. And we'll talk about that. We'll go through the nomenclature. I'd like to use the North American Spine Society, where any extrusion of the disc beyond the margins of the vertebral bodies end plates is called a herniation, and these are divided into protrusions, of which there are several kinds, extrusions, and diffuse bulges, and they're thought to have different clinical significance. What's important if they're localized protrusions is the location, the size, whether it compresses a nerve, and then we need to look at postoperative changes, which we'll talk about. So let me start out here. Elior, how common is it, if you did MR scan on a bunch of children, how common is it that you would find abnormalities in the lumbar spine in children?
I think low, maybe 10%.
Okay. So you'll find this that this study was done in Sweden. If you did a large number of children, just randomly selected, you'll have about 9% at age 8, which will show MR findings. By age 19, it's 60%. Well over half will have what we consider significant MR findings. About 14% of children will present to their doctor with significant low back pain. And if you look at 19-year-olds, about 15% will already show disc desiccation. And as we say, about 60% will show some abnormality. So the bottom line is that these diseases that we're going to be talking about start very early at age. So what we really would like to be able to do with MR is, well, I mean, the things that I think we need to recognize right now is that there's just a lot of data to show that our management of spine degenerative disease has really been a medical failure, or it's very expensive. Our outcomes are very poor. It's very costly. A lot of medical treatment is actually leads to worse disease than it actually helps. And now, if you talk to a lot of your friends or your parents and so forth, you'll probably find that when it comes to spine surgery, they've all heard horror stories about spine surgery. And so the general public is very suspicious of their medical profession when it comes to spine surgery. We need to understand the pathophysiology of the disease, and I don't think we fully understand it yet. We need to use MRI to detect degenerative changes, but then we have to figure out how to treat this disease early on to stop the degenerative process, and we need to understand what the significance of MR abnormalities are. We have to figure out how to stop or slow the development of degenerative disease, and there are things we know to try to do this. So let's talk a little bit more detail about the discs, and we'll talk about degenerative disc disease. And then later on, we'll talk about ways to actually protect the disc and so forth. So the disc is really the normal disc, has a nucleus pulposus in the center, which is a gelatin. Around the edges, you have Sharpie fibers and annulus fibrosus, which holds the gelatin in place in the center part of the disc. You have a little bit of bulging at the edges, which is normal and physiologic. And then you have the end plates on either side. Now, what is the disc for? These discs are flexible. If you didn't have a disc, the spine would be rigid and would be much less functional. The disc also is designed to dampen vibrations and pressure, which comes from acute spine loading. The trabecular bone in the end plates is very brittle. And if you have a lot of certain frequency vibrations or acute loading, especially if it's in a certain location and not distributed throughout the entire end plate, this can cause fractures of the end plate trabecular bone and lead to degenerative disease. So the disc is very important, just like the menisci in the knee. The discs are important to protect the adjacent vertebral bodies, and it's important for normal function. So this is what it looks like histologically. There's a central nucleus pulposus. Here are Sharpie's fibers and the annulus around it. Here's what the gross specimen looks like. The nucleus pulposus here, Sharpie's fiber and the annular fibrosis around the periphery of it. Now, degenerative disease, this is from a paper from England, JMRI in 2007. There are two things that can happen to cause degenerative disease, and they actually both happen simultaneously. You can get in-plate injury. This can decrease the nutrient supply, because what you see in a lot of cadavers when you look at people with degenerative disease, you look at the end plates, they're highly sclerotic, and the sclerosis then displaces the small arterioles on the end plates, and they decrease the amount of blood supply that gets to the end plate, which is important for diffusion of nutrients into the disc. So end plate injury leads to malnutrition of the disc and death of cells within the disc itself. It leads to decreased glucose and O2 within the disc, decreased cell metabolism, increases pH, and increases lactic acid. This leads to loss of the glucosaminoglycans and aggregans, which are the ground substance of the disc. This leads to dehydration and volume loss. That leads to disruption of collagen fibers. That leads to tears through the Sharpie's fibers in the annulus, which then leads to herniation of the nucleus pulposus outside the disc. And then once you lose the normal height of the disc no longer functions properly to protect the end plates, and you get further end plate injury. The other thing that happens is you can disrupt the annulus due to trauma. This can lead to disc herniations, volume loss, dehydration, loss of glucosaminoglycans. That can lead to end plate injury, decreased nutrient supply, and the whole process. And it can become a vicious cycle in both areas. So we want to try to stop that process if we can. And this just shows what the disc looks like. This is an area where it just shows the end plates. This shows the vascular supply into the end plates. So just like that cartoon we saw before, here's the actual visualization of the end arterioles going into the end plates, which then lead to nutrient supply, which diffuses into the disc. And if you look at the diffusion, what you find is that the diffusion is very slow. You can see the lactic acid is very high in the center of the disc. It goes much lower off to the periphery, and the PO2 is high in the periphery. It becomes very low in the center, and you have very low glucose in the center too. So this leads to death of a lot of cells in the center over time, which means you no longer produce proper glucosaminoglycans and aggregans, which are the ground substance that this needs to function and survive properly. Now, this was a study done with MR where they injected contrast and they looked at signal intensity and therefore actually how rapidly it takes for contrast to diffuse into the disc. And what you see here, it really takes almost 2 hours before you get a significant diffusion of contrast into the discs. And that's a reasonably good marker of glucose. So it really takes many hours for nutrients to diffuse into the disc. And this is if it's not being used. Now, and this is also true for articular cartilage. And anybody have any ideas how you might be able to speed up that diffusion so that you give better nutrients to the cells?
Loading and unloading.
Good. Loading and unloading. Loading and unloading. We have better studies in the articular cartilage, but loading and unloading markedly increases the speed of this diffusion by compressing and forces water out of the disc. Decompressing sucks water back in along with nutrients, and it can markedly improve the diffusion of nutrients into the disc. And this is one of the main reasons why sitting and being inactive for long periods of times is really bad for the disc. That actually being upright and loading and unloading the disc is very important for normal disc metabolism and physiology. So that's why a lot of people nowadays will say that you really need to get up and walk around at least every hour. And one of the reasons why we like to walk to lunch. So I think this is important for all of us. And this is probably one of the more important ways you can protect your spine from degenerative disease. And this just talks about why cells need nutrients to survive. This is really a nice article in JMRI from 2007. And I won't go through all this. This just goes through some of the biochemistry involved. And this just shows those vessels. They also showed in here how when you get sclerotic disease, you lose all these vessels going to the end plates. And with sclerosis, you can actually block the pores and therefore decrease the nutrient supply at the end plate. And therefore, if you have less, even if you have more diffusion, if you have fewer nutrients to diffuse, you're going to get lack of nutrition to the cells within the disc. And then it's also shown in this article that if you have traumatic vertebral fractures, they're associated with increased degenerative disc, which is in large part probably due to this process. And this is one of the first papers that actually looked at how to grade degenerative disc disease with MR, where you can see this is a Thompson grading system, 1 through 5. More recent one, based upon this basically thing, which is very similar, is the Fearman classification, which was published in 2001. The Thompson one was published in 1990. So you can grade this. I don't use this in regular when I talk about desiccation, but I don't actually go into the different Thompson or Fearman classifications when I read a study. This is more for clinical trials, I think. Now, there's something called the internuclear cleft, and this has been debated over some time as to what its significance is. It's seen in a lot of younger people, so it's thought to be normal. It's probably relatively normal. You can see decreased signal in an MR scan here, but this paper really looks into the details of the histology of the disc, shows that this is actually compression of fibrous bundles, which are in the nucleus pulposus, and is an indication of early desiccation of the disc. Not of clinical significance, but it's probably not a normal finding, which a lot of people talk about. In this histological study of 320 disc spaces seen in cadavers, this just shows how commonly you'll see abnormalities. So degeneration is really seen in a high percentage of 83%. But these are primarily older individuals who went to the autopsy table. But we'll come back to some of the data they had comparing histology to MR scans a little bit later. Why don't we stop here, and we'll talk a little bit about discography and these how discography has been used to look at disc disease tomorrow. Okay? Any questions?
No.